To go ahead and talk about the patient who presents with URI symptoms. I know this sounds like a pretty basic topic, but like all things, we should have a systematic, algorithmic approach to these patients to make sure that we don't miss any life threat. So let's go ahead and get started. Now, this is your patient who presents with fever, cough, maybe has a runny nose. So the first thing that we're going to need to do, like with any other chief complaint, is to develop a critical differential diagnosis. Whenever we see fever, we always think of pneumonia, UTI, and cellulitis, as these are the most common causes for fever. We can also add meningitis and myocarditis / endocarditis. Because you have this critical differential prior to approaching this patient, in your history and physical, you'll be sure to ask whether the patient is having a productive cough, if there are any signs of dysuria, hematuria, or urgency, any new skin changes or rash, whether the patient is having meningismus on physical exam, or if there's a new murmur or some tachycardia that's out of proportion to the fever. So now that we have our critical differential diagnosis, let's go ahead and get to our algorithm. Your first question is going to be whether there are any wildcards. These are going to be your patients that are immunosuppressed, so maybe they're on chemotherapy or have AIDS or on some kind of weird rheumatologic medicine. These are also your very old and very young patients. And also you'd want to consider patients with cardiac or pulmonary disease, like CHF and COPD. If the answer to that is yes, then all bets are off. If the patient has a fever, you really want to take a second and reconsider all of your critical differential diagnoses and make sure you work up your patient for that. These patients all have a higher rate of mortality with even simple URIs, and that's why we need to be more diligent about our management of them. So for your workup, you could consider getting a CBC, a basic metabolic panel, a UA to assess for UTI, blood cultures, lactate, an influenza swab, and finally a chest x-ray to assess for pneumonia. If the patient is immunosuppressed and has a fever and any signs of meningismus or altered mental status, you really got to consider getting a lumbar puncture. These are the patients that you really want to spend time doing a thorough history and physical. You want to make sure that you look at all of their skin, including the gluteal creases, to make sure that you're not missing an abscess somewhere. You want to make sure that you check for meningismus or any signs of altered mental status. You'll really want to do a thorough cardiac exam, listening for any new murmurs that could be consistent with endocarditis. If you see JVD, crackles at the bases, lower extremity edema, and tachycardia out of proportion, you'd want to consider myocarditis. So that's the scary scenario. But let's say that the patient does not have any of these wildcards. As long as the history and physical are inconsistent with any of the other critical differentials on our diagnosis, the next question that I ask is whether or not I should get a chest x-ray. To figure that out, I ask the patient how long they've had a productive cough. And if it's greater than 1 to 2 weeks, and the cough is productive, then I'll usually get a chest x-ray to make sure that there isn't a pneumonia. If it's been less than 1 to 2 weeks, I would just discharge the patient home with symptomatic management and not do a chest x-ray. There are multiple different guidelines and rules that try to help you determine whether or not you should get a chest x-ray in this patient population, but in general it kind of seems to be a moving target. The idea is that not everyone who presents with URI symptoms needs a chest x-ray, especially if they're only presenting with 1 to 2 days of symptoms. The last thing that we'll talk about will be the influenza swab. In the patient who is immunosuppressed or has one of the wildcards, it's an important test to get because if the patient has influenza, you're going to do everything in your power to treat it, which is to give Tamiflu. Now, the efficacy of Tamiflu has started to come in doubt, and as a result, in the patient who presents with no wildcards, getting an influenza swab wouldn't be particularly helpful because it wouldn't change your management. So even in the patient that presents with less than 72 hours of symptoms and has a positive swab, given that the efficacy of Tamiflu is in doubt, it's probably not necessary to prescribe them Tamiflu or any other type of medications because they should be able to recover from the flu. So unless your ID department is trying to track how many influenza cases your department is seeing, it's probably best to avoid the influenza swab in a patient without any wildcards, as it really doesn't change your management of the patient. For more information on Tamiflu and its efficacy, you can go to the reference section of the show notes. And that's about it. So hopefully this gives you a nice clean algorithm to follow every time you see a patient who presents with a URI, and that way you'll be sure not to miss one of the live threats.